Hey everyone, welcome back to Discussions with Dr. G. I'm Dr. G, your snarky but lovable pharmacology professor and host for this ride into the wacky and sometimes wild world of behavioral health meds. Today I want to get real about bipolar disorder. And let me tell you, there's a lot more to it than just mood swings, which I think is a phrase invented by someone who's never seen mania at 2 a.m. Pathophysiology-wise, you've got wild swings in neurotransmitters, the manic highs, the depressive lows, all thanks to this chaotic dance between dopamine, serotonin, GABA, and norepinephrine. The actual circuitry feels like someone hotwired a house and called it good. And what does this mean for someone living with bipolar disorder? Well, daily life can feel like you're driving a car with a stuck gas pedal and no brakes. Unpredictable mood swings, difficulty sticking to routines, even higher risks for things like cardiovascular disease, not to mention the day-to-day challenge of staying employed, keeping relationships, just holding it together. Seriously, there's a huge impact on health outcomes. All right, so first up, why do folks develop bipolar disorder? Well, if you've got a first-degree relative, like your dad or your sister, diagnosed with bipolar, your risk is, get this, about 80 times higher than the run-of-the-mill population. That's massive. The genetic link is strong, but it's not just about faulty DNA. You have environmental stress, trauma, and especially sleep disruption. These are huge triggers. And then there's the neurological stuff like neurotransmitter imbalances and a little something called mitochondrial dysfunction. But if I start in on mitochondria, I'll be here until next Tuesday. So let's break down the types because trust me, people mix them up. Bipolar 1 is classic. Full-blown mania lasting at least a week. We're talking about racing thoughts, impulsivity, sometimes even psychosis, and major life disruptions. Then you have bipolar 2, which flies under the radar. Hypomania, which is like mania's little cousin, just not quite as destructive. And depression. And of course, substances can set off similar symptoms. So someone binging energy drinks or, something less legal might look manic, but it's actually the meds or the drugs talking. And here's a sobering bit. Health impacts for folks with bipolar disorder are rough. We see way higher suicide risks, and this part always floors my students. Life expectancy can drop 10 to 20 years because of all the associated risks, cardiovascular disease, diabetes, metabolic syndrome. There's a reason why treating and assessing this stuff correctly is so incredibly crucial. Oh, speaking of assessment, one time I had a student come up to me convinced she was hypomanic. Turns out she was just jazzed for her pharmacology exam. Not quite the same, folks. It's these stories that drive home the point. If you don't know what real hypomania or mania looks like, you'll miss it in your patients. And that's dangerous, right? Assessment is half the battle, or more than half on some days. So let's talk about the million-dollar question. What do we actually use to treat bipolar disorder? And you know what? It's rarely ever just one medication. It's pharma soup. Pick your flavor. Mood stabilizers, antipsychotics, anticonvulsants, antidepressants, and sometimes, a sprinkle of benzodiazepines when things go really sideways. So let's start with mood stabilizers. Lithium is the OG here. It calms down those irritable neurons, works on those sodium channels, GABA, serotonin, dopamine, the whole gang. But, and it's a big but, lithium has a super narrow therapeutic window. Think 0.6 to 1.2 milliequivalents per liter for maintenance and up to 1.5 milliequivalents per liter for acute cases. Too low, nothing happens. Too high, you're in toxic territory. You've got tremor, nausea, confusion, seizures, and if you let it go, a one-way ticket to the ICU. It's been around forever. It's still the gold standard. We do use it for acute mania, as a maintenance medication, even for suicide prevention, and sometimes treatment-resistant depression. But man, oh man, you have to respect lithium. And just so you know, lithium toxicity can look like GI upset and tremor at first, but can quickly spiral to confusion, seizures, and even a coma. Fun, right? Absolute contraindications. Folks who are pregnant, or have serious renal issues, or are dehydrated, or are sodium depleted. We nurses are basically amateur chemists with all the levels and labs we've got to monitor. Serum lithium, kidney, thyroid function, sodium levels, the whole shebang. Plus teaching patients about lifelong therapy and the importance of hydration and steady salt intake. And of course, don't just stop your meds because Aunt Mabel read something online. Now, on to antipsychotics. We have two main generations. First gen, like haloperidol. They work fast by blocking dopamine D2. Great for acute mania or agitation, but at the price of stuff like EPS, or extrapyramidal symptoms. That's dystonia, akathisia, tardive dyskinesia, all those gnarly movement disorders. There's also a risk for neuroleptic malignant syndrome. You heard me, NMS. Plus, anticholinergic stuff like dry mouth and constipation. Not exactly a party. Then you have your second generation. Quetiapine, risperidone, olanzapine. They block both dopamine and serotonin, so they work for both manic and depressive phases, as well as for maintenance. Downside? They can lead to metabolic syndrome, which is weight gain, diabetes, cholesterol issues, QT prolongation, and changes in prolactin levels. So we're checking A1Cs and lipid panels left and right. Next up, anticonvulsants. These are the mood stabilizers' cousins, like valproic acid and carbamazepine. Great for mania, lamotrigine for bipolar depression, but they come with some serious, pretty epic boxed warnings. Liver issues, blood problems, and with lamotrigine, that infamous rash, Stevens-Johnson syndrome. Trust me, if you never forget the first case of that. Anyway, we monitor labs, tell clients to report any skin changes, and pray to the pharmacology gods that there are no rashes. Antidepressants, especially SSRIs like fluoxetine. These are used for those depressive swings, but never by themselves in bipolar. Otherwise, you risk flipping a patient right into mania or rapid cycling. So, these need to be paired with a mood stabilizer or an antipsychotic. Otherwise, it's like giving coffee to someone with insomnia. Just no, okay? And they take forever to work. Like, remember, 2 to 6 weeks, antidepressants? So you need close monitoring for any signs of switching into mania, agitation, or that dreaded increased suicide risk. Lastly, benzodiazepines like lorazepam. This is for those out-of-control acute manic episodes. Benzos enhance GABA for sedation and anxiety relief. It's really handy in, like I said, acute mania with agitation or insomnia. But they're kind of like inviting a tiny gremlin. Tolerance builds up fast, and dependence and withdrawal risks are no joke. They are just for short-term use, tapering slowly, and no, seriously no, mixing with alcohol or opioids. They are mainly used to calm the agitation, treat the insomnia until the real, quote-unquote, meds kick in. But they're the classic use with caution, dependence, respiratory issue, and never, ever stop them cold turkey. You do not want withdrawal seizures. Trust me. Name of the game in bipolar pharmacology is safety, safety, safety. Okay? Assessment is your bread and butter. Watch for mania, depression, new side effects. Got a client who's a little more restless or suddenly way more upbeat than usual? That's a red flag. And if you see tremors, GI upset, or those random unexplained rashes, don't just chart it, act on it. Could be the start of something serious, especially with lithium or lamotrigine. As nurses, we're monitoring toxicity with a microscope and a crystal ball. Lithium, checking levels, hydration, kidney, thyroid, valproic acid and carbamazepine, CBCs, liver panels, mood shifts, rashes. If they start bruising or spiking a fever, it's like an all-caps email to the prescriber. Antipsychotics get metabolic panels, movement assessments, and take your blood pressures sitting down and standing up. Orthostatic hypotension still catches new grads off guard. Half of what we do is patient and family education. Drink enough water. Don't go on a keto, sodium-busting fad diet. Show up for your labs. And seriously, if that tremor gets worse, don't just Google it and panic. I actually had to say that to a family once who kept second-guessing every symptom their son had because he was on lithium. So I started saying, look, when you're in doubt, check the label and call the office, not Dr. Google. It took a while, but eventually they became the best lithium toxicity watchdogs. Education is where nurses shine, or at least where we nag best. I tell my students all the time, this is a lifelong gig. Clients can't just stop their meds, even if they feel better. Adherence keeps relapse at bay. And let's be honest, it's the nurse who teaches clients and families to spot the danger signs. Suicidality, confusion, skin lesions, you name it. Now, none of this med management works without watching lifestyle. Healthy diet, exercise, skipping on the booze, trying to sleep on a regular schedule. These are as non-negotiable as the meds. And sorry to say, patients aren't always excited to hear it. So we've got to get creative. I once wrote a lithium song to help students remember the toxicity. Ready? Tremor, tummy ache, always check the salt intake. It's not going to win any Grammys, but I swear it'll stick. Anyway, let's bring it home to the day-to-day realities. What makes nursing in psychiatric health both challenging and, a little exhausting? Good clinical judgment is essential. You're always looking for cues, mood shifts, lab abnormalities, side effects, all of it. The hard part, prioritizing what's actually going on. Is the patient agitated because their levels are off, or is it a genuine mood episode? Is that tremor from lithium, or are we looking at an emergent neuro issue? Finally, team up. Psychiatrists, social workers, fellow nurses, families, we're all on the same team. It isn't just about managing the meds. It's about keeping people as safe and stable as possible for the long haul. And honestly, that team-based approach is the real secret sauce in preventing disasters. All right, folks, that's the magic of bipolar medications. Chaotic, sure, but with a decent plan and maybe a song or two, entirely doable. If you want to keep digging into behavioral meds, stick with me for more war stories and practical wisdom next time. Until then, may all your lithium levels be therapeutic and your patients trauma-free. All right, semi-trauma-free. See you next episode.